Okay, we'll entertain questions for 5 minutes until 1:45 when lunch will be served. So if you can hang on to your hypoglycemia for 5 more minutes.
We have a question here for Dr. Gray. Is there a size below which a pancreatic net should not be removed?
That depends on which data you look at, how old it is, and which surgeons you talk to. I think, one, the diagnosis of a neuroendocrine tumor of the pancreas, to find it, first of all, has to be of a fairly large size, in my opinion. So if you found it on a CT scan, it's probably greater than a centimeter in size. I resect all of them. I do it immediately as soon as we make the diagnosis, and before I do that, I would look at the MIBG scan, the octreotide scan, the CT scan, to make sure there's no other tumor in there, because if you're going to go in to do the job, you should try to do it properly or as best you can so that there's no more tumor burden in there, or there's no more tumor whatsoever. So you need to correlate your octreotide scans and MIBG scans as well, making sure there's nothing in the liver that Natalie has to get as well, and I take them out. Yeah, and if you're referring to anything like gastrinomas as well, it's the same sort of thing. There used to be old studies that said, well, you don't need to operate on these unless they're 2 centimeters or getting bigger than 2 centimeters. That's totally wrong now. The cat's out of the bag by then, and the lymph nodes are positive by then, and you've decreased someone's survival by not operating on them.
Yeah. Right. Natalie?
I think we have this question at Tumor Board pretty frequently, because you will find lesions that are in the head of the pancreas especially, which becomes very troubling. So you do have to take and balance how it was found, if it's hormonally active, and then patient characteristics, because you certainly don't want to be subjecting someone to a Whipple who's not going to be able to tolerate it. And I think that's most often the gray area.
Yeah, no pun intended, right?
But that does make it a bit more difficult when they're small and asymptomatic in an older patient.
Okay, Jim, looks like you have another one.
Okay, well, thank you. Here's another one for Dr. Gray. All speakers have emphasized the importance of patient knowledge and involvement in treatment. How do we short-circuit privacy problems and, quotes, records department reluctance in producing documents as simple as scan results for patients?
I think every patient's allowed to have their own reports and their own scan reports, and that almost always can include a CD of your scans.
Mm-hmm.
That's the access to patient care. I don't think that's a problem.
Yeah, I would agree completely. That's every patient has a right to their records and also to their CT scan. It's not a problem. It shouldn't be a problem.
Can I make a comment about that?
Sure.
I've had.
Sorry, I can't see you.
It's Dr. Asset.
There.
Sylvia
Asa from Toronto.
Thank
I'm
you.
a pathologist. And I've had a number of people ask me questions like this, and I think it's really important for patients to know your patient records, including your CT scans and your pathology, belong to you. As physicians, we maintain them for you, but you have every right to obtain your own records and your own pathology, and if you would like second opinions, it's your right to request that material either be sent to the physician of your choice, or that you take it to that person, or you can have it sent to them. I think any issues around privacy where a hospital tells you you can't have something sent because of privacy regulations, they're just blocking you. I think you really have to be aware of that as patients.
Exactly. Thank you.
Sylvie sees a lot of that because of the Ki-67 problems and people not being able to diagnose or tell what a Ki-67 is. So a lot of people want their pathology re-looked at with respect to what's the Ki-67 index is for their prognosis.
Okay, Jim.
These are related. It seems to me we've opened a door here. But the issue of second opinion related to that, surgeon education, how and when, where, related to, if a surgeon says the tumor is not resectable, yet another says the surgery can be done, is this just an indication of surgical skills?
That's a very interesting question, and I
We
think
leave it with you.
Leave it. Yeah. No. I'm gonna give Dr. Gray and Dr. Coburn a chance to answer.
I think it is often a matter of opinion or experience. I think most of our cases we bring to tumor board, and we all sit around and look at the cancers, and I'm sure you do that at Western as well. So if you have a situation where several surgeons are looking at your films, you may only see the one person who's talking to you in the clinic, but usually in the larger centers there is a tumor board, so there's a set of surgeons who will sit around and look at the films and discuss whether it's resectable or not. Now, usually Dr. Law sits in the back corner and makes chicken noises.
Yeah.
But we do take into account how difficult it is and what our goals are in resecting these things. And I think that if you're just simply told by one person it's not resectable and another person it is, the truth probably lays somewhere in the middle, and that it must be a very difficult resection. So you do need to think about what you're gaining from the resection to remove the tumor.
Yeah, I'll agree with what Nellie said, but I'll add something. It depends on, she's in a big center, I'm in a big center, so we have a whole lot of help that we have at our disposal. So if you're coming from a center where there's a smaller surgical staff and they may not have the backup, they may not have the confidence to do this operation, and they know they can't do it in their center. And because they've never done it in their center, they think that it's not doable because they've never actually seen it done before. So a lot of these cases that I'm seeing, I've talked to the surgeon afterwards that said, I couldn't take this out. It's, how did you get this out? We don't do it here. That's a good reason for a second opinion. I have the help of vascular surgeons if I need them. I have a fantastic hepatobiliary surgeon that comes in and helps me if I need him. He's great. And they support, and I have a huge backup in an ICU if things go sideways. I have a huge amount of support in my center that you coming from a smaller center with another surgeon might not have the availability to, so they don't want to get into trouble operating on you, and maybe they can't do that operation in the center. It's not just the surgeon that's involved with this, it's the whole center that's involved with this. So I think a second opinion is great, and when you get to big centers like Toronto or London, then we do talk to them and talk about it in a board type fashion, and we say, you know what, Doug, let's do this, or Natalie, I think you and I can do this together. And we'll say, okay, we'll take it on.
Exactly. That's my final comment on that, is the fact, the importance, as Dr. Gray mentioned and others have mentioned, centers of excellence, where an individual surgeon by himself or herself in a small center can't tackle some of these heroic operations that you saw today. But somebody in a bigger center with all the necessary vascular, HPB, backup, etc., ICUs, can deal with that. And again, so it goes back to the concept of centers of excellence. Okay, according to my watch, it's 10-1. Yes?
If I may ask just one question to both.
Okay, we're going to give you the final word.
Okay, thank you very much, because I'm struggling with this. I would like to know, let me ask the question, have you ever tipped a liver over that was heavily involved with the removal of a primary, number one? And what criteria do you use to operate when a liver may be heavily involved by Doppler ultrasound? Do you use the biochemistry to make your decision before you operate, or how do you make that? Because we've had some bad, unfortunate situations where everything is ready to take the primary out, and the surgeons they see the Doppler ultrasound and they see 75% tumor burden, and they are hesitant to do the surgery. And
okay.
I just need to know, have you seen have you tipped anybody over with heavy burden when you
Natalie,
took the primary out?
When you take a primary out?
Yeah.
When you take the primary
out with a loaded liver,
loaded liver.
have you tipped the liver over?
I can't think of any that we've done that way. With colorectal metastases, we tend to have more problems with liver failure because they're having chemotherapy.
But not with neuroendocrine?
Not with neuroendocrine, but
Okay.
I think a Whipple might tip somebody over if they had a 95% replacement of the liver. So a Whipple might be the one where I would worry.
I agree completely with Natalie. In my personal experience, I've never tipped somebody over just taking the primary out. even if they have, let's say, 75% of the liver replaced, they can usually tolerate removal of the primary. But Natalie is right. If it's a Whipple, then it's a different story. It's a different category of operation.
So biochemistry as well, liver function studies, or like total bilirubin or something would.
Any comments there? No. Okay. Well, thank you very much for your attention, and off to lunch.